Hi there. Thank you for allowing me to join and talking in this wonderful conference. My name is Christina Fanola, a vascular cardiologist and imaging specialist with the University of Minnesota Physicians and Health Fairview. I was on the American Heart Association and American College of Cardiology Aortic Guideline Writing Committee, and I'll be giving an introduction to thoracic aortic disease and updated guidelines and diagnosis and treatment. This is our publication from 2022, the Guidelines for the Diagnosis and Management of Aortic Disease. It's open to the public for review. I'll be going over some highlights today. So the biggest change that we want to discuss is what is a aneurysm? So we have new thoracic aortic definitions, and historically the standard definition of an aneurysm is 1.5 times expected diameter of a vessel. Well, this is not applicable to the root and ascending aorta. So, for example, if we have a normal aorta at 3.5, does that mean an aneurysm doesn't exist until 5.3? That wouldn't make sense. So we have new definitions. We use 4.5 centimeters for aneurysm and 4.0 centimeters for dilated. For patients with height or body surface area outside of 1 to 2 standard deviations of the mean, we use aortic size index, aortic height index, and cross-sectional area to height ratio. So the new dilation threshold, why 4 centimeters? So this is consistent with 2014 European Society of Cardiology guidelines, in which aortic dilation was similarly defined as 4 centimeters. This comes from data looking back from the International Registry of Aortic Dissection, so the IRAD registry. What they found was that the relative risk of aortic dissection exponentially increases once you reach a diameter of 4 centimeters, compared to that of less than 3.4. In addition, we avoid using the term ectasia in aortic root and ascending aorta to avoid confusion. We also try to avoid mild, moderate, severe phrases in describing the dilated aorta or aneurysmal aorta. And for example, when we report it out now, we say the aortic root is an aneurysm, it's 4.6 centimeters, and we use very absolute terms. So how do we measure and report the aortic root and ascending aorta by our different imaging modalities? So nothing's changed much with echocardiography. We do a 2-dimensional long axis view. We measure at the root, the sinotubular junction, and the mid-ascending aorta. We measure 3-dimensionally, short axis view, the sinus or the root. What's changed is that currently we recommend doing sinus to sinus to measure the maximum root diameter, but there's also sinus to commissure, and that's been commonly done historically. On MRI and CT, you want to measure at various segments and report these out. You want to understand if you have an aortic aneurysm, where exactly it is located along the aortic root or ascending aorta. So there's the root, the sinotubular junction, the mid-ascending aorta, the distal ascending aorta, the aortic arch, the proximal descending aorta, and the mid-descending aorta. If there's an area of growth or an area in particular that we're doing close surveillance on, we want to make sure we're very particular about which segment we're monitoring closely. Here's an example of the very crucial point of sinus measuring and of the aortic root. So to the left there is the sinus to commissure measurement. You can see that's 51 millimeters. And to the right, there's the sinus to sinus measurement, that's 56 millimeters. So clearly, if we had one measurement reported one year and we did another measurement the following year, we could see there'd be a huge discrepancy. So when you look at your diameters of your patients or yourselves and you're monitoring your aneurysm, you want to know exactly where it's being monitored and how it was measured. So here's a summary of guidelines on aortic imaging from our publication. So I just wanted to box the highlights. So first of all, limit radiation. If you can choose MRI over CT as much as possible, especially in younger patients, that's recommended. Also doing ECG gating on your CT and MRI imaging. We do inner edge to inner edge mostly, unless there's plaque or aortitis, and outer edge to outer edge. For the root measurement, we do sinus to sinus. And then also a 2A recommendation now is to consider using those size measurements as indices. So aortic size index, aortic height index, and the cross-sectional area to height index as well. Here's a comparison of the various imaging modalities. So CT and MRI obviously are best for three-dimensional imaging, especially if there's asymmetry of the root. But you want to do echocardiography if you're looking at valve function. So if you have aortic regurgitation or aortic stenosis, you always want to complement your CT or MRI imaging with an echo. I usually order both echo and CT or MRI together as complementary surveillance plan imaging. You also want to have a comprehensive report and understand exactly what's going on, especially post-dissection patients. So in addition to doing diameters, you want to look at abnormalities of the aortic wall, thrombus, diffuse thickening, atherosclerosis, look at areas of luminal stenosis, occlusion, if there's an aortic syndrome present, where the entry tear sites are, complications, malperfusion issues, and then also classification. Post-repair patients, we have to look at pseudoaneurysms at the area of suture lines, and then anything else. It's good to know if it's ECG gated or not. So the next slide here is the multidisciplinary aortic team concept, so the MAT. This is new to the 2022 guidelines as well. So this concept similarly went after the heart team approach to valve disease several years ago. It includes having a multidisciplinary set of subspecialties get together for mainly acute acute aortic syndromes or aortic aneurysms, confusing cases that might need repair, but it's not clear. So this might involve genetics, neurology, vascular surgery, perfusion specialists, anesthesia, cardiology, cardiac surgery, etc. It also is really important to work very closely with your radiologists, educate them on how to report out the updated guidelines in aortic disease and surveillance recommendations. So why do we use a multidisciplinary aortic team? So both single center and multi-center studies have demonstrated mortality benefit with the use of multidisciplinary aortic teams in surgical repair of aortic disease. So this could be both remote or local. So if there's a rural center that does not have one, usually there's access to a consultative service at a larger center nearby. There's also the concept of high volume aortic centers. So this is from a study from 2016, included over 53,000 thoracic aortic surgeries. So there was a clear decreased mortality seen with annual institutional volume cases greater than 20, and even more significant mortality reduction at 50 or more cases per year. So what do the 2022 guidelines say about multidisciplinary aortic teams? So for patients with acute aortic disease that require urgent repair, it's a class 1 recommendation to call a multidisciplinary team. So for example, we have a code aorta service at our institution. And then secondly, so if patients are asymptomatic with extensive aortic disease or who may benefit from complex open or endovascular aortic repairs, or with multiple comorbidities or anything that makes this really complex, referral to a high volume center is definitely recommended, and especially where there's experienced aortic surgeons. So I'm going to shift now. This is the new nomenclature, causes of thoracic aortic aneurysms. This gets a little confusing, but the first concept here, we changed is something called the heritable thoracic aortic disease. This is very confusing, but I'm going to walk you through this. So the first part is syndromic. These include Marfan syndrome, Loeys-Dietz, vascular Ehlers-Danlos. There's also non-syndromic, HTAD. These are your gene-positive familial types, gene-negative familial types, and sporadic. Sporadic is your younger patient. They might be in their 50s. They have no known family history, and then they also have negative genetic testing. In addition, there's congenital, which we had before, bicuspid aortopathy, Turner's, and coarctation. We still have inflammatory, infectious, traumatic. And the thing that's changed is that we no longer talk about degenerative as much. So if you have a younger patient, might have risk factors, we have to really think about what is at the cause of the aneurysm here. Does a 55-year-old with well-controlled hypertension have a degenerative thoracic aortic aneurysm? Probably not. There's probably a hereditary component there that has to be worked up. So now I'm going to go into the syndromic types of thoracic aortic aneurysms. So there's Marfan syndrome, autosomal dominant with the FBN1 mutation. This is a dysregulated collagen synthesis disorder. So I try to look at imaging clues to Marfan's on echocardiography. You see the sinuses of Valsalva are progressively dilated. There might be sparing of the sinotubular junction and the proximal tubular aorta. There actually may be then dilation again of the descending aorta. The root is pear-shaped, so annulo-aorta-ectasia, and then they can also have mitral valve prolapse and main PA or pulmonary artery aneurysm. Phenotypic features of Marfan syndrome, so tall with elongated arm span, dental crowding, high arch palate, joint laxity, pes planus, pectus deformities, arachnodactyly, ectopic lens, pulmonary blebs. Now moving on to Loeys-Dietz syndrome, this is a very, very severe disease that can have 6 subtypes with various genetic mutations here. De novo inheritance has been observed. It's really important to elucidate the genetics behind Loeys-Dietz if it is suspected, as this actually guides treatment. So phenotypic features of Loeys-Dietz. So 48% have root aneurysms. Others, most of them actually have peripheral involvement. They'll have other aneurysms, head, neck, iliacs, coronaries. They may get valvular disease. The problem with Loeys-Dietz is that there is possibly the early rupture risk for them. So aortic dissection can actually happen without dilation. So these patients should not have delay in referral to an aortic specialist and gene testing. Ehlers-Danlos syndrome is the next one. In aortic disease, we specialize in vascular EDS. That's a COL3A1 gene mutation. So these patients, it's also a collagen processing mutation. Patients present with smooth, translucent skin, delayed wound healing, small joint hypermobility, narrow set eyes, thin nose, small lips, loveless ears. Old data suggests a major event by 40 years and 80%. However, I would say that that is changing. We're getting much better at diagnosis, prevention, and vascular Ehlers-Danlos. And so I have many patients that have lived 60, 70 plus years old without a major event, thanks to our preventive care. They can also get additional aneurysms, and so screening is very important for them. The next category of heritable thoracic aortic disease is familial type. So this is non-syndromic HTAD. So all of these listed mutations are possible for familial type. And it's important to know this. Family history clues in to this diagnosis. They may or may not have some physical features of syndrome, but they don't meet classic criteria. They have usually aneurysms presenting at less than 60 years old, and then a family history of aneurysms in first-degree relatives or unexplained sudden death. So it's important to know the mutation type for these if there is one positive. Patients can present with aortic dissection at small aortic sizes. The next disease state is bicuspid aortopathy. So this is a common prevalence overall. 50% will have an aneurysm, and then 10% of bicuspid valve has coarctation. So I always get a MR angiogram or CT angiogram of the chest to make sure they don't have that. They can have coronary anomalies. And then what's important about bicuspid aortopathy is that risk of dissection is higher at similar aortic diameters than that of tricuspid valve types. So do not delay referral to an aortic specialist in these as well. This is a photo that I actually saw, I present to all my patients when I describe their disease. So when you have a bicuspid valve, the one on the left there is normal. Basically a normal tricuspid valve, you pump blood out. The red flow there, that's where all of the pressured flow tends to concentrate right in the middle of the lumen of the aorta. When you have a bicuspid valve or fusion of 2 of your leaflets, then you get eccentric blood flow. And basically the flow is now hitting the side of the aortic wall, and then alterations in flow lead to regional differences in wall shear stress and then these proteolytic events, and that can increase your risk for dissection. So if we were to look at them with a microscope of the aortic wall in someone with bicuspid aortopathy and an aneurysm, we could actually see these little pockets of smooth cell loss there and proteolytic events, which leads to dissection in some cases. So moving on to indications for gene testing. We're very proud of this addition to the aortic guidelines. So basically, when you go through patients, so they have a thoracic aortic aneurysm, they have any syndromic features, they have family history, they're young, send them to gene testing. If they have a sporadic type, no family history known or no known syndromic features, and they're older than 60, then you can suggest screening in first-degree relatives. And then if any of those relatives have an aortic dilation or aneurysm, then you can go forward with genetic testing. And if you have a positive result, you can do cascade testing and then also gene-based management or treatment. The next concept here is something we added to the guidelines, shared decision-making. So this is extremely important. So, not every patient has the same disease. And clinicians can present the information, do the gene test, do a physical evaluation, do imaging. Ultimately, this is up to the patient as well. How does this diagnosis affect lifestyle? How would potential surgery affect lifestyle? What are the options for surgery? What are the options for waiting and doing surveillance? All of these things go into a decision-making and how to manage an aortic aneurysm. So now we're going into surgical thresholds. I'll try to walk you through this in a very stepwise approach. This is for gene-positive syndromic HTAD, so things like Loeys-Dietz syndrome. So you see here, you do gene testing, TGF, BR1, BR2, etc. You can see the aortic diameters, surgical threshold is as low as 4.5 in some, 4.0 in others. That depends on if they have high-risk features or not. And then this is the slide for surgical thresholds for gene-positive syndromic HTAD with Marfan syndrome. So 5 centimeters for all, but then you can lower that threshold to 4.5 if you have high-risk features. These include family history of aortic dissection, rapid aortic growth, diffuse aortic root, and ascending aortic dilation are marked for vertebral arterial tortuosity. You can also suggest surgical intervention if their DSA to height ratio is more than 10, and then when possible, do valve-sparing root repair with an experienced surgeon. This slide shows surgical thresholds for gene-positive non-syndromic HTAD. So these are your familial types of thoracic aortic aneurysm. So remember that these gene mutations can dissect at small aortic diameters. So over on the right, you can see that aortic diameters of as low as 4.2, depending on presence of risk factors, can actually lead to a patient needing elective repair earlier. Surgical thresholds for gene-negative, non-syndromic HTAD. These are more of your sporadic types. So shared decision-making is extremely important in these patients. We can't really predict the future. More needs to be known about these types. If they're asymptomatic and no high-risk features, then we suggest elective repair at 5 centimeters. If they're asymptomatic but have high-risk features, again, rapid growth, family history of aortic dissection or unexplained death, then 4.5 centimeters could be considered at an experienced aortic center. What about surgical thresholds for bicuspid aortopathy? So 5.5 centimeters for all, or if they have high-risk features, again, rapid growth, family history, also a root phenotype. So if the root starts to dilate with a bicuspid valve, that is a high-risk feature, then we consider elective repair at 5 centimeters. Now, something to consider is your TAVR patients or surgical aortic valve repair patients. If patients have severe aortic stenosis or regurgitation and a root size of 4.5, you should also consider a complete Bentall valve replacement plus ascending aortic repair at 4.5 centimeters. So this is a summary slide, surgical thresholds for gene-negative sporadic aneurysms. So on the left, aneurysms that are symptomatic, no matter what, you go to surgical repair. If they're asymptomatic and less than 5.5 centimeters, think about their risk factors or their height ratios. Consider surgical repair at smaller diameters if there's abnormal growth or if they meet criteria based on their height. So going through medical therapy, this has not changed much from prior guidelines. So beta blocker and ARBs are still recommended if tolerated. We try to do both for all patients if blood pressure allows. And for blood pressure, aim as low as tolerated. For antiplatelet therapy, if they have concomitant coronary disease or other atherosclerotic disease that can be considered, consider statins, even in the absence of atherosclerotic aortic disease. And for acute aortic syndromes, we still recommend anti-impulse therapy, pain control, ICU, and CCU level care. Now, a lot of patients ask us about this, physical activity guidelines, both for aneurysm and post-repair. So for patients with significant aortic disease, education and guidance should be provided about avoiding intense isometric exercises. This includes heavy straining, Valsalva maneuvers. Basically what I tell patients, if you're bearing down, trying to lift something that's too heavy, avoid burst exertion activities like CrossFit, and also collision sports. And for patients who have undergone surgery for aortic aneurysm or dissection, post-operative cardiac rehab is now recommended as a class 1. So it's a huge win for us in the guidelines because no insurance will actually pay for it. And patients absolutely love cardiac rehab, gives them confidence, builds them back up physically and mentally. So that's recommended. And then for aerobic intensity or aerobic exercise, we recommend 30 to 60 minutes of mild to moderate intensity, at least 3 to 4 days per week. And then lastly, and there will be another conversation about this in another talk, but screening for anxiety, depression, post-traumatic stress disorder is crucial for these patients and to provide resources for support in this case. And that's all I have for today. Again, thank you for this wonderful conference. Sorry not to be there in person, but please feel free to reach out to me for any questions, and I've left my email there below. Thank you.